The next talk is Dr. Kapadia, is percutaneous LV assist device, and the surgical side and the practical or technical side he would be discussing.
Very good afternoon. Very enjoyable session. I thank to the organizing committee for inviting us for this particular topic. In fact, our experience in India about the ECMO, the percutaneous LVAD and heart transplant is not great, but somewhere we have to initiate. And in that initiation, I and Dr. Ravi Kumar joined together 7 years ago with the motto that we'll develop this a day, and now we are happy that we have done a lot of this kind of things. As we know that there are 670,000 new cases of cardiac failure diagnosed every year in USA. In India, I don't know how many. The chronic heart failure can be managed with the medical therapy, maximum medical therapy. They keep coming to the hospital, they keep coming to the ICU. Ultimately, the destination, either heart transplant, because of the shortage of the organs, is not offered. Many of them die. The LVADs and other measures are very costly. Now, heart failure therapy in acute coronary syndrome, myocarditis, drug-induced, Dr. Ravi mentioned a lot of things. I don't want to go into details. But when the medical therapy fails with maximum inotropic support, we have to look beyond the intra-aortic balloon pump. That is my message to the audience, especially in the acute coronary syndrome with severe cardiogenic shock. These are the young patients who come with unsupported non-collateral coronary circulation, and when they have the LAD tertiary infarction, many of them die even with the IBP. Some dilated cardiomyopathy because of the acute on chronic failure. The indications will discuss, but before the end organs, kidney and livers are affected, we have to look into this. The LVAD temporary, which can be placed percutaneously through median sternotomy, right or left thoracotomy, or destination therapy, of course, through the left thoracotomy or median sternotomy, and of course the transplant. Now, the mechanical circulatory support for cardiogenic shock following the acute myocardial infarction, there are a lot of difficulties because the patient coming, there are the logistic issues or financial issues. Before the consent comes from the primary PCI, the things are delayed. Many times delayed referral, thrombosis may fail, there is a risk of bleeding. All this I don't want to go details, but the things are very complicated. In spite of that, we have to look beyond IVP, and we have to think about the ECMO, which can be rapidly initiated in the cath lab within 7 to 8 minutes time if the ECMO team is alerted, and that's what we do nowadays. And once we are satisfied that the ECMO, there is a chance for recovery, the neurostatus is good, the kidney is there, the liver is not affected, this patient can be very well converted into percutaneous ventricular assist device like Impella. The tandem heart is still not in India. We are trying to get to India. We are negotiating with the company. Now, IBP, of course, discussed can initially stabilize the patient, but it cannot improve the LV. And for it to be successful, the LV has to be at least 35 plus. Now, short-term devices, as Dr. Ravi Kumar mentioned, as a bridge to recovery, as a bridge to surgery, many times the PCI is not possible. Many times there may be rupture of interventricular septum, MR, or ventricular aneurysm, bridge to the transplant, bridge to the long-term LVAD. So what is the aim of the temporary LVAD? The aim is to decompress the LV, to reduce the LVDP, to improve the cardiac output, to improve the end organ function, of course to improve the lungs. It can be easily inserted in the cath lab itself, percutaneously, because the femoral punctures are done, and like Impella can be inserted to the femoral artery, the tandem heart can be inserted to the femoral vein. The cardiopulmonary bypass is not required, there is no bleeding. The indications are, of course, emergency PCI already discussed. The one point of attention is the most of the successful PCI, the stent myocardium is forgotten, and these are the guys who may sometimes have non-responsive malignant ventricular arrhythmias, low cardiac output, in spite of the fact that there is a complete opening of the culprit vessel with a good flow, TIMI flow, 3. And our experience of all the cardiologists, most of them, they have the experience with the balloon mitral valvuloplasty. Routine arterial puncture, even the arterial puncture and venous puncture can be done in the ER, in the emergency rooms. We can always look for Impella, which I'm going to show that we already have started in India. The tandem heart, of course, is a costly affair. It costs about 70,000 and the disposables to 7 to 8 lakhs. But it could be a good thing to bridge the patient without the use of oxygenator and complications. Now, PROTECT II trial, as you know that this is, I immediately go into what was the background. The IBP and Impella device were actually compared in the randomized trial, PROTECT II trial. This was the design. And this was a very well study done, 2008 to 11. And what they found that the outcome of acute coronary syndrome patient with PCI, with Impella, the results were much better. And this is the curve. You can see the green one, the Impella one, the less mortality. So this is the outcome definitely with the wide gap between IBP and Impella with a good p-value. Now, so what is the conclusion? That Impella type device can hemodynamically support following PCI is safe. It can provide a good flow, 2.5 to 5 liters. The only problem is because of the high rotation, it can cause hemolysis. So this is the kit available, and it consists of the 12 French catheter with the inflow and outflow the ports. The inflow is in the LV, outflow is in the aorta. Easy to insert. That's what it is. And you can do the echo, transesophageal echo. You can see the position. You can control the flow. There's another one, catheter pump, which is called return pump, which is also, can be utilized for this. But it is all trial things. But my main aim is now to talk about the tandem heart, which is the P-LVAD, which can be placed percutaneously. Now, beauty about this is it is inserted through the femoral vein, transseptal puncture is done, and it decompresses the LV right away, reducing the risk of pulmonary edema. No oxygen is required, but in due course of time, if the lungs become bad, you can connect the same thing to the ECMO circuit. What we have to do is we have to put another femoral venous cannula, and this becomes like a 2 inlet cannulas, and then you have to get the arterial access in the femoral artery, which is already there. So it can be converted either way. Now, the cannula size is 21 French size. The Luotronic is another one which has got the noiseless function. It's a very costly affair, but it can support as a temporary weight for a period of even 6 months. It has been tried. It can be utilized for the biventricular support as a bridge to transplant, as a bridge to permanent LVAD. Now, this is the patient who had Centrimec. He is doing the exercise. So, ECMO for cardiogenic shock, already Ravi has described in great detail. I don't want to go into details. But the Make a Cardio Help is the smallest machine. It can be put in the ambulance. In fact, we can bring the patient from secondary care center to the tertiary care center on ECMO following the cardiac arrest. And that is a part of advanced life support protocol now in Europe. The biomedical centrifugal pump is also available. It's cheaper version, but it causes more problem of hemolysis. The best pump is the Rota pump or Centrimec Luotronic. Now, this is one of our patient who had cardiac arrest following, just before we could take him in the cath lab, we put him on ECMO, then assisted PCI was done. This, if you see, there is distal cannula, which is taking care of the distal perfusion. And without any limb complication, only one patient we had out of 46 or 47 we had done. Now, after the ECMO, what is next? If the LV recovers, wean off. LV dysfunction continues to worry, change to the P-bed. If initially patient was put on percutaneous weight, then wean off if LV recovers. If not, release the patient for transplant or look for permanent LVAD. The only problem is the area of concern, the ventilation, infection, bleeding, intervention, sometimes multi-organ dysfunction. There are various types of LVADs available. The most popular is HeartMate 2. The HeartMate 3 is coming next year. InCore, which is the Berlin Heart. The X score is for the pediatric external support, Jarvik 2000, and hardware. HeartMate 2, hardware, Berlin Heart, Jarvik, these are probably possible to do in India. We were the part of the first HeartMate 2 in India. That's how the patients are doing well. Jarvik 2 also is another device. Our experience of ECMO is for respiratory cardiac failure, Elevate using Biomedicus, Mackay, Leotronic, Percutaneous Impella, PulseCath, bioventricular support with Leotronic, permanent Elevate with HeartMate 2, the first Indian experience. This is the patient on the third day post-op. That's the intra-op picture. It's a bulky device, but can be very well placed above the diaphragm. That is our news coverage. Emergency room, I have one guideline to be given. As soon as a patient comes, young patient with cardiogenic shock or impending cardiogenic shock, please take the femoral, venous and arterial puncture with the 5 sheath. As soon as the patient is shifted to the cath lab, before he crashes, the PCI can be started, IBP can be inserted. So conclusion, we have to look beyond the IBP, percutaneous VAD is easy once one-time investment done. The tandem heart is most ideal but costly, Impella is cheaper, easier to insert through the femoral artery, sometimes subclavian and axillary artery also. ECMO should always be considered first. The PO8 is control conditions later if indicated. Thank you very much.
Thank you, Dr. Kapadia. Nice presentation. We welcome any questions from the audience, any comments.
It's a vast topic and lot of things, and I know that those who are into it, it takes a lot of efforts to initiate the program.
Any experience on your own personal experience you would like to comment on such cases? Because I am sure that this treatment is going to be the treatment of the near future, and next 5 years I am sure you would be using it very frequently in your practice. One question, Kapadi. Right now I think Tandem Heart and Impella both are in the process of being registered, DCGA. So you think the use of ECMO would be very practical? And if it can be inserted fast. So how fast can you insert an ECMO?
See, ECMO always gives you breathing time. The many patients who come, they are in pulmonary edema with low PO2 and acidosis. So I think easier to start the ECMO, and then we can later convert into whatever you like, Impella or Tandem Heart. Because if you stabilize, we do successful revascularization, you don't have to worry for the oxygenations and acidosis and other things. Because you are going to give heparin anyway for PCI, so that breathing time is there. And other thing is, you are right, sometimes better to avoid ECMO because you cannot give protamine in this patient because there will be a stunt occlusion immediately if you give protamine. So Impella, if you have got, it could be the preference.
How fast can you institute ECMO in the CCU, without even shifting?
CCU, if you have got the pre-prime circuit, and if you alert the ECMO team, it can be started within 7 to 8 minutes. What it takes is just put the percutaneous cannula. Sometime, that's what I was mentioning, if you got a 5F sheath, you can just put in 7 to 8 minutes. Because the pre-filled circuit is there, you have to just connect and start on ECMO. By at the most 15 to 20 minutes, in one case we have taken almost 1 hour, but they continued to give CPR and that patient really did well. So it is possible. We have also done ECMO and transplanted this patient and they are alive. So I think whichever is possible, ECMO should be the first guideline, I think.
Thank you. Thank you.
Thank you.